ட்ரீட்மெண்ட் பண்ணும்போது யூரின் வரும். ஏன்னா வந்து ரத்த ஓட்டம் கிட்னிக்கும் இன்க்ரீஸ் ஆகும்போது வந்து பாத்ரூம் போகணும் போல இருக்கும். அதனால் வரும்போது பாத்ரூம் போயிட்டு வந்துடுங்க. என்ன மாத்திரை சாப்பிட்றேன்றதை எனக்கு சொல்லுங்கள். சில மாத்திரையை வந்து ட்ரீட்மெண்ட்டுக்கு அப்புறம் போட்டுக்கணும். மற்ற மாத்திரை எல்லாமே கண்டினியூ பண்ணுங்கள். மாத்திரை ஏதாவது சேஞ்ச் பண்ணுமா குறைக்கணுமான்றது வந்து ஒரு 15 நாள் ட்ரீட்மெண்ட் போய் முடித்த பிறகு சொல்லுவோம். ஒரு சார்கிட்டையும் கன்சல்ட் பண்ணிவிட்டு அப்புறம் குறைக்கலாமா வேறு ஏதாவது மாத்திரையை மாற்ற முடியுமான்றது பார்ப்போம். ஸோ இந்த ட்ரீட்மெண்ட் அப்போ சில டெஸ்ட்டும் பண்ணுவாங்க, அதெல்லாம் பார்த்துக்குவோம். சரிங்களா? இது எல்லாமே கவர்டு. உங்கள் ட்ரீட்மெண்ட்டுக்கு கவர்மெண்ட்டுக்கு சார் எழுதி கொடுப்பார். அதை வச்சுட்டு இங்கே ட்ரீட்மெண்ட் ஸ்டார்ட் பண்ணுவோம். உங்கள் இது வந்து கார்டு வச்சுருக்கீங்க, ரேஷன் கார்டு. அது சார்கிட்ட நான் பேசுகிறேன். இப்போ ஸ்டார்ட் பண்ணும்போது லைட்டாக பிடிக்கிற மாதிரி இருக்கும், அவ்வளோதான். ப்ரெஷர் ஸோ நான் கையில் கொடுத்தேன்ல உங்களுக்கு பிபிக்கு, அது வந்து ஆல்மோஸ்ட் வந்து 200 வரைக்கும் கொடுத்தேன். ப்ரெஷர் கொடுத்துட்டு கொஞ்சமாக குறைச்சேன். ஸோ காலில் வந்து இப்போ அது 80 ப்ரெஷர் கொடுக்கும். இந்த ட்ரீட்மெண்ட்டில் மேக்ஸிமம் ஒரு 260 300 வரையும் போகும். ஸோ வந்து ஒரு 260 தாண்டும்போது மட்டும்தான் லைட்டாக இருக்கும். அது ஒரு 2-3 நாள் நீங்கள் வரும்போது ஒன்றுமே தெரியாது. யூஸ்வலாக ட்ரீட்மெண்ட் வரவங்க ஆல்மோஸ்ட் ஒரு 60% வந்து ட்ரீட்மெண்ட் அப்போ தூங்கிடுவாங்க. அதனால் வந்து டிஸ்கம்ஃபர்ட்டு பெயின் எதுவுமே இருக்காது. இன்கேஸ் ஏதாவது டிஸ்கம்ஃபர்ட் இருந்ததுன்னா, இந்த லைட்டாக பிடிக்கிற மாதிரி இருக்குது, வலிக்கிற மாதிரி இருக்குன்னா அவங்ககிட்ட சொல்லுங்கள், கப் இது பண்ணி பண்ணிடுவாங்க. இந்த யூஸ்வலாக எவ்வளோ தூரம் வாக் பண்ணுவீங்க? ஒரு 10-5 வருஷத்துக்கு முன்னாடி நல்லா வாக் பண்ணுவீங்களா? என்ன வேலை பண்ணிட்டு இருந்தீங்க? அப்படியா? 15 நிமிஷம் கொடுப்போம். ஸோ வந்து எவ்வளோ மேக்ஸிமம் ப்ரெஷர் இன்னும் 5 நாளில் கொடுப்போமோ அதை இப்போ கொடுத்து உங்களுக்கு காட்டும். இப்போ ப்ரெஷர் இன்க்ரீஸ் பண்ண வந்து உங்கள் பிளட் ரத்த ஓட்டம் ஹார்ட்டுக்கு வந்து இன்க்ரீஸ் ஆகும். அந்த இன்க்ரீஸை மட்டும் ஒரு 15 நாள் கண்டினியூஸாக வச்சுருந்தாலே Professor Muthukumar to make the arrangement at such a short notice, and we have already installed one unit of EECP in the 3rd floor for patient with refractory angina and heart failure. Today my presentation would be to elicit what is EECP, mechanism of action, clinical outcome and patient selection. I will try to be as brief as possible so that I can able to complete in maybe 20 to 25 minutes. I graduated from Karnataka. Then I was doing my internship in Stanley for 1 year. Then I studied in JIPMER for non-PG for 1 year. Then I took an USML. I went to US, where I joined in Stony Brook. And there I wrote an article on EECP which got accepted in American Journal of Cardiology. So the company recruited me as a clinical guy, and I worked with Stony Brook University and FDA to give objective evidence for the treatment so that it can be cleared by FDA and the insurance company. So some of the papers which I published also, I'll just give you a glimpse. So if you look at here, Enhanced External Counter Pulsation, it's a non-invasive, atraumatic, in the sense it is neither an interventional procedure nor a medical management. It's a device-based treatment for patient with angina and heart failure. The treatment is already approved by FDA, and it is also covered by medical insurance in US. And recently in 2012, the treatment was incorporated in the Chief Minister's scheme, and it has been reimbursed for the patient, eligible patient who are called refractory angina and heart failure. So before getting into the what is EECP and actual mechanism of action, I just want you to freshen up something on the basic hemodynamics of cardiac circulation. If you look at here, the aortic pressure and left ventricular pressure. Whenever there is an increase in left ventricular pressure, that actually happened during the systolic phase. If you look at the down, the systolic phase, the blood flow into the coronary vascular bed is very, very minimal, which is only 20% of the circulation. And the maximum coronary filling takes place only in the diastolic phase. So it has been speculated and also has been intensively researched any treatment which can push the blood into the coronary circulation during the filling phase or the diastolic phase would have the immense benefit to the myocardium. Because in the systolic phase, the myocardium contracts as well as the coronary arteries are squeezed in the wall so that the blood flow is very minimal. So this concept was already utilized what we call as an intra-aortic balloon pump. So they have a maximum diastolic pressure so that augment the coronary filling so that the coronary vascular bed is flooded with the blood. And if you want to treat any patient with cardiovascular disease, if you want to make it very, very simple as possible, it comes under two categories, which is a balance between demand and supply. So either you can able to take the demand away from the myocardium so that let the myocardium function with a less energy, or you have to improve the supply to the myocardium. So if you look at reducing the demand or afterload, which is achieved by all the medical management we do, like a nitrate, calcium channel blocker, AC inhibitor or ARB. But if you want to increase the supply to the myocardium, the only way you can achieve is by an interventional procedure. Either you have to graft, which is a bypass surgery, or you have to open the vessel, which is an angioplasty. So these are the two techniques which can improve the myocardial perfusion directly. So it is always imagination or what we call like a revolutionary idea from the any interventionalist or any researcher is there any treatment which can do both in a device wise? So that is intra-aortic balloon pump, but unfortunately intra-aortic balloon pump can be inserted into the aorta only a couple of hours or couple of days. It cannot be left for a longer period of time, and it is the only treatment available for the cardiogenic shock when the myocardial salvage has to take place. So EECP is the same as intra-aortic balloon pump, non-invasive, which can be used in a chronic phase. So that is how it has been positioned as a treatment for chronic stable angina. So what actually EECP does? Enhanced External Counter Pulsation, as I said, is completely a non-invasive procedure. So it uses 3 sets of cuff in the lower region, lower calf, lower thigh and upper thigh region. The patient is lying down on the treatment table where it is hooked to the ECG. So the ECG, as if in the intra-aortic balloon pump, can able to find out exactly where the diastolic phase and exactly where the systolic phase take place. So during the diastolic phase, where you can able to fill the coronaries, because the coronary filling happens during that period, we give a pressure of around 300 millimeter mercury pressure. This amount of pressure is translated into increasing the circulation into the coronary vascular bed. So this increase in blood supply, what it does to the coronary vascular bed is a hypothesis which I am going to explain as a mechanism of action. So the patient, as a treatment starts, comes for 35 days. Every day, 1 hour, continuously for 35 days. During the 35 days, he is getting to pump the blood from the lower leg towards the coronary. So the coronary flow is augmented. So as a synonymous, what I can say is, it is equivalent to a patient who cannot even walk for 2 minutes, actually is acting a make of a jogging. So that amount of blood supply is increased into the coronary vascular bed without patient is put on into any effort. So what is the actual mechanism of action? As I said before, EECP is a form of non-invasive intra-aortic balloon pump. Intra-aortic balloon pump is positioned in the aorta, EECP cuffs are positioned in the legs. So here if you see, there are 3 sets of cuffs in the calf, lower thigh and upper thigh region. Exactly during the diastolic phase, the cuff squeezes the leg. So there are 2 compartments. One is an arterial compartment, one is a venous compartment. So it gives the compression to the arteries as well as veins. So here there is a differentiation. In intra-aortic balloon pump, there is no venous component is involved. Here in EECP, there is a venous component is involved. When it is compressed, the arterial blood go in a retrograde direction. Because the aortic valve is closed, because it's timed exactly during the diastolic phase, the blood enter into the coronary vessel with a higher velocity and higher pressure. So when this higher velocity and higher pressure of blood enter into coronary vasculature for a prolonged period of time, up to 35 days, it stimulates what we call as collateralization or angiogenesis. It can stimulate new vessel formation, and also it can able to open up the dormant collateral which is already existing into the vascular bed. And second is a systolic phase. When the heart is ready to pump, the cuffs deflates. So what it happens is, it creates a drastic reduction in the peripheral vascular resistance. So the heart can able to pump blood easily into the dilated vessel, as if it is taken a dose of nitrates. So basically, it reduces the afterload and increases supply. So the question frequently asked when the FDA get the clearance for EECP for in 1999 is, you put a pressure on the leg. Do you have any evidence to show the amount of pressure you're putting on the lower leg actually translated into increased pressure into the central hemodynamics? So it's only in 2008, one surgeon, Michael Andrew from Florida, he used a radial approach, put a catheter and put it in the intracoronary and start actual pressure tracing during counter pulsation. To the surprise, if you say in the baseline, you can see there is a systolic, dicrotic notch and downsloping diastole. And they start applying a pressure 100, 150, 200, 250, 300 in the lower leg. And to the surprise, what they find out, whatever pressure you applied in the lower limb is actually translating into the pressure into the central hemodynamics. If you see here, the diastolic pressure as you start getting in baseline 100, 150, in 150, you can see the diastolic pressure slowly coming up. When the pressure reaches up to 250, you can see the diastolic pressure or the diastolic curve is double than the systolic curve. So this is what we call as a diastolic augmentation. So you are augmenting the blood pressure into the coronary circulation during the diastolic phase, and to the surprise, it's much better than what intra-aortic balloon pump can achieve. Because here we are using the vasculature and pushing more volume than IABP can do. And incidentally, if you look at the systolic amplitude, you can see the systolic amplitude is coming down. So this is what the effect we call as the afterload reduction or unloading of the left ventricle. So the left ventricle is unloaded, so the demand is reduced, so the oxygen consumption in the myocardium reduced, and the supply is increased. So both the main criteria for treatment is angina is achieved during every cycle of EECP. And this is a curve to show how much of diastolic pressure is increased. Is almost 92% increase in the diastolic pressure and 150% increase in the diastolic velocity. So overall, the mechanism of action is increased blood supply to the myocardium is translated into the new vessel formation, which we call angiogenesis. And also because of the sheer volume of blood which is moving up and down in the body, as if the patient is doing exercise, what it does is, it started improving the endothelial function. So the endothelium naturally started secreting more nitric oxide and endothelium level falls. And we always remember endothelial function is a predictor of outcome and also predictor of mortality irrespective of your coronary stenosis. You might have a 50% or 90% stenosis, but you have an endothelial dysfunction, your chance of getting myocardial infarction or unstable angina is higher. So this treatment also improves your endothelial function as if you are doing an aggressive exercise. But actually it is a passive exercise without putting you on any effort. So second is when I said angiogenesis, new vessel is formation. New vessel formation is a very, very complicated process and books has wrote, there are a lot of books on it. To make it very simple, there are two ways to assess whether you have achieved angiogenesis or not. One is we call as a myocardial perfusion scanning, thallium scan, or a PET scan. So in 1992 to 2003, our group did the maximum of around 200 patients. The patient pre and post myocardial perfusion scan show a significant improvement of perfusion to the ischemic area after 35 days of EECP. That is an indirect evidence to show the collateralization taken places. So this is our paper which got us into the insurance companies in US. I just want to point it out to you. To assess the patient's collateralization, number one, you have to ask them to do a treadmill. Let's say he do a treadmill for 4 minutes. After 35 sessions of EECP, ask him to do the same 4 minutes. Even though his exercise capacity is improved, if you keep the workload same and do the perfusion scanning, 83% of the patient, there is a significant improvement in perfusion, which can be directly related to angiogenesis. Or push him harder. Ask him to do as much exercise as possible after treatment. Still about 54% has an improvement in perfusion. This shows collateralization is already occurring in the myocardium. So these are all the perfusion scan which we did couple of patients in Frontier. You can see pre and post. The ejection fraction jumped from 30 to 42% because of the global improvement in the blood flow. And also you can see the scanning that the bright area shows us, the blue area shows ischemia and the bright red shows the flow. You can see pre and post. Visually, you can definitely see there is a significant improvement in perfusion. And finally, it is always a stumbling block because the gold standard, if you want to say there is angiogenesis taken place, the gold standard will work as a collateral flow index, which can be done by the catheterization. So until 2010, there is no study to directly show collateralization. In 2010 and 12, there is two groups. One is the angiogenesis group in Germany, another in Switzerland. Both did the same protocol. They took one group of patient with EECP with no pressure. So they gave very low pressure, another one with an active counter pulsation, and they were able to show the patient who undergone active counter pulsation, there is a significant increase in collateral flow index. That shows angiogenesis is happening. So the proof for angiogenesis, the growth factor increase and also collateral flow index and myocardial perfusion, all clearly shows beyond doubt new vessel can be stimulated, flow can be increased in the myocardium without putting a stent or a graft by EECP alone. But patient selection is a paramount important, which I'm going to show you a little bit later. So again in 2010, the Cardiology Journal of India has reviewed EECP for patient with refractory angina and heart failure. So if I put on EECP, what is the outcome? As every physician, we want to know after applying EECP, what is an outcome on this patient? Would they able to sustain the benefit for the longer time? So already there is a 3-year follow-up study has already done, which clearly shows even after 3 years, 75% of the patient were able to retain the clinical benefit which they got after post-EECP. And there are some of the trials which I don't want to go into detail. All of them have shown more than 5,000 patients has been followed up to 6 months, 1 year, 2 year and 3 year. All has shown around 70 to 85% of the patient were able to retain the benefit even after 3 years of the counter pulsation. And second is angina is a heart failure. Heart failure is because what we call as a systemic failure. It is not only a myocardial dysfunction, but also the systemic failure because of the endothelial dysfunction. Here again, patient with heart failure, 86% were able to reduce the emergency visit after EECP, and almost 83% were able to reduce the hospitalization time after post-EECP. If you follow them for 2 years, patient with severe LV dysfunction less than 35%, we all know their mortality is very high, rehospitalization is very high. But after EECP, it is not a randomized trial, it is an epidemiological survey which shows almost 2 years follow-up, 83% of them are alive, and almost 70% of them have not visited the hospital, which shows EECP significantly have an effect on the patient with heart failure. So let's finally go for a couple of slides on patient selection, as we are very important. EECP can be given as a primary utilization for patient with angina and heart failure who are on maximal medical management, still they have angina and poor quality of life, and again they are not a candidate for interventional procedure because of a lot of other reasons. The reasons has been listed below. Patient refused. If they have a diffuse vessel disease where stenting is not possible, or the target lesion is inaccessible, high risk for surgery, or patient with comorbid illness which have a high incidence for risk while proceeding the interventional procedure, or patient with severe LV dysfunction. So this is a FDA list. The intended use for EECP is stable, unstable and heart failure. Indication minimum there should be a class 2 and class 4. Whether it is NYHA or CCS, they have symptomatic irrespective of maximal medical management, and they have been evaluated and they seems to be not a candidate for interventional procedure. And some of the contraindications are very similar to what you do with the intra-aortic balloon pump. You should not have an aneurysm, you should not have a valvular disease, or you should evaluate them for deep vein thrombosis. So to summarize all, the mechanism of action is EECP significantly improve the myocardial blood flow by collateralization and angiogenesis, and also it has a significant improvement in endothelial function. If you look at the clinical evidence, more than 85 to 90% of the patient, there is a significant improvement in quality of life, and the improvement in quality of life they got post EECP is sustainable even after 3 to 5 years of completion of the treatment. And also the treatment has shown to be safe and effective even in patients with high risk for interventional procedure and also who are comorbid illness. So finally our focus is, most of the focus is on a ischemic heart disease, or we call it as a coronary artery disease. But the focus is, it is ischemic heart disease and coronary artery disease are a subgroup. As a whole, we have to look at it as a cardiovascular disease. So improving the myocardial perfusion and reducing the afterload, which on the effect on the systemic circulation is much more important than only focusing on the coronary artery itself. Thank you. So what is the advantage and disadvantage of EECP when compared to IABP? So in my slides, I've clearly shown EECP is very comparable to the IABP on its effect on the cardiovascular disease. So if you look at IABP is life-saving in acute even, in a cardiogenic shock. And EECP has not, no trial has been done on EECP. That is why where IABP fail is in the chronic state. If you have a chronic angina, you are not going to expect to put IABP to increase the myocardial perfusion. EECP is a safe alternative for patient with chronic stable angina, where the effect of IABP can be provided by EECP into this chronic patient, where the myocardial perfusion improves. Number second, IABP does not have any effect on the venous system. Two, EECP has an effect of, because we are compressing the leg, not on the aorta. So we are also increasing the preload. So increasing the preload in patient with right heart failure or patient with have a high pulmonary artery pressure, PA pressure more than 50 or 60 is dangerous because it may cause us a pulmonary edema. So IABP does not have this because it's not even affecting your venous return. But because it increases the venous return in a patient with stable heart failure, EECP can improve the cardiac output and the patient feel very better even after 5 sessions of EECP. Yeah, the role of EECP in acute coronary syndrome. The indication in FDA clearly says EECP, because it is similar to IABP, it is also a treatment for cardiogenic shock and acute myocardial infarction. But unfortunately, so far, there is no trial has done on acute coronary syndrome. But actually, there is one trial, it's going on in Germany, in patient who come, as we talk about the balloon time, balloon to bedtime. Patient come in, so you want to push in your the kinetic streptokinase into the circulation. At the same time, you always remember, when a patient have low blood pressure, low cardiac output, whatever you are pushing, because of the sluggish flow of the circulation, the endless circulation, the drug might not reach the target. So there is one study to find out if you put EECP along with thrombolytic, can we able to have a higher perfusion when compared with only thrombolytic. Other than that, there is no studies available, and probably next year, June, this study is going to be published. Yes, sir. Possible. So it is in patient with low output, even if you put the thrombolytic, it might not reach the target. So it will be given as an assist, like a ventricular assist device. It can assist the circulation to reach the where the thrombolytic has to go. How long improvement lost in your study? Right now, there was a registry in US in Pennsylvania. They are following up the patient. The maximum number of years they have followed is up to 7 years. So they have shown in 7 years, almost 65 to 70% of the patient, they have retained the benefit without undergoing a repeat procedure. In US, the insurance companies allow the patient to go for EECP after 3 years to improve the myocardial perfusion. So definitely the patient who we are talking about is inoperable group. So in that patient, sustaining the benefit to 3 to 5 years, we will have a good quality of life and have a sustained decrease in the medical input of the patient. So I would say the follow-up of 5 to 7 years, the treatment benefit could be sustained. Thank you. Fine, sir. Thank you, sir. When EECP for first introduced, the first contraindication is heart failure. Because they thought, because it is going to affect the venous return, it is going to cause pulmonary edema and worsen the heart failure. But unfortunately, later from our epidemiological trial, it came up to say EECP is a treatment for heart failure. But hemodynamically, we can look, there is also one study which I didn't show up. When you put a pressure of 300 millimeter in the leg, the preload increase in patient with heart failure. Then what happened? The right heart pressure increase, pulmonary wedge pressure increase, and pulmonary edema develops. But if because EECP reduced the afterload significantly, much better than IABP, this flow which is going into the pulmonary started shifting into systemic because of the drastic reduction in afterload. So here, whenever we take a patient with low ejection fraction, we make sure the pressure we are applying is high, so the afterload is achieved. So if the afterload reduction is achieved significantly, you might not have a pulmonary edema. But if you don't achieve the afterload, the chances of pulmonary edema is very high. So it's a treatment we have trained our doctors and therapists how to reduce the afterload significantly during the treatment so that to avoid patient to go for a heart failure. Heart failure. Refractory angina. The heart failure improvement has been shown, sir. I mean, if you don't put the myocardium into... Definitely, sir. If you look at our data... Yes, sir, that's why. Let's say if a patient with 35% ejection fraction, now we are putting counter pulsation. Definitely, as you contemplate, the preload will increase, right atrial pressure will increase, and then pulmonary wedge pressure increase and pulmonary edema happens. But EECP has a tremendous effect on the afterload. So it also increases the cardiac output, and if your afterload reduction is significant, the deflation of the cuff timing is kept correctly, you might not develop pulmonary edema. In fact, your cardiac output can be increased. So in our data of 5,000 patients, 80% of them are triple vessel disease with LV dysfunction. So in this group only we have shown, that is how the FDA is cleared for heart failure. We give oxygen. For நிறைய patients நீங்கள் பண்ணும்போது அந்த PA pressure 50 இருக்கும்போது after EECP it will drop. So the placebo effect which is always there in any medical device management. So you put any device or you put any intervention, there is always a question of what we call as a placebo effect. So if you want to say my treatment does not have any placebo effect, means a randomized trial is a must. If you don't have a randomized trial, and even if you say 90% of the patient did improve quality of life, they can walk larger, again the chances of placebo effect is almost 60. But EECP right now has 7 randomized control trial to show the same patient come for EECP with no pressure has no improvement at all. Only the patient who undergone active counter pulsation have a sustained effect. So I would say the placebo effect may be 10 to 15%, but not as much as 60 or 65%, which is related to the device. Because we have also shown some of the objective evidence like ejection fraction improvement, reduction in BNP, improvement in myocardial perfusion, and improvement in collateral flow index. So these are all some of the objective evidence to show diastolic augmentation. So this case also I was discussing how the diastolic augmentation has improved in one patient. We did a 15 minutes. In patient with heart failure, the main complaint is fatigue, lack of appetite, and extreme tiredness. In EECP, what happened when you push the blood, within 3rd day he would say, I feel better. It has nothing to do with your cardiac, nothing to do with angiogenesis. It's just an improvement in cardiac output which is given for a sustained benefit. So the tiredness, all these things goes off within 3 days just because his blood flow is increasing, which he can achieve if he can able to walk 15 minutes every day. The only problem in heart failure is they cannot even walk for 2 minutes. So this could be augmented as an increasing in the working capacity by increasing in cardiac output. Pulmonary hypertension, sir, if the pulmonary hypertension is more than 50, we don't do EECP. Because pulmonary hypertension is one condition, if the inflation and deflation time it's not done absolutely correct, there is a chance of going for pulmonary edema. 60 pulmonary hypertension, but we are doing all the patients now. With 60 also we give oxygen to the patient and we monitor the pH. Yeah. Elevated pulmonary hypertension, we may have to provide oxygen. It's not a contraindication, but you have to be careful. RV dysfunction is something difficult. And what we do is if they have a dilated LV more than 6, COPD, no. But we have a lot of studies. Some of the nephrologists are referring because, no. In patient with contraindication. If you have a severe aortic regurgitation, then it is absolute contraindication. If you have a mild to moderate, we can do, but any severe valvular condition might be a contraindication. Not studied, sir. It's a gray area, yeah.
We are doing a study going on with lighting therapy.
Yes.
We are doing heparin and we are giving high dose of aspirin and opioid. We are giving low doses. When you inflate the systolic beat up to 300, what is the risk of bleeding in situations?
Yeah, I mean, this is in FDA safety. As I said, that is why I showed the EECP, very similar acute hemodynamics when compared to the IABP. So even in acute coronary syndrome, they are doing EECP, there is no condition of bleeding or cerebral bleeding or cerebral rupture, and no case has been documented even after 10,000 patients of safety study. EECP for cardiac. None of them have any bleeding complication or cerebral hemorrhage or internal hemorrhage, no. But As you said, if you are taking on a warfarin, any of the anticoagulant, we do a INR and we'll try to manage the INR should be less than around 2.5. If it is more than 3, 4 means probably you have a bleeding, but petechial hemorrhage, not internal bleeding. When you do EECP, when you stop, the patient will have like red patches on the leg. That is because of the petechial. That happens if your INR is more than 3. So if you are on a patient with anticoagulant, try to make sure you take an INR level and say, and sure it is make less than 2.5. Yeah, I mean, this is good because low pressure. See, I mean, if a patient comes up with the edema, there are various causes. Even if it is because of varicose vein and all these things, when you put EECP, within 20 minutes the edema disappears. But again, if it is a varicose vein, it is going to come again when you stop the treatment. But many patient has what they say is weight loss. In a patient with obese patient with LV dysfunction, most of the load is because of the fluid overload. When you do EECP, urine output increases and the patient LV function improves, and maximum 5 to 10 kgs of reduction in weight also has been mentioned in the literature. But reduction is because of the fluid overload has been corrected, not because of any fat or anything has reduced. So in a heart failure patient, there is a weight reduction because they are overloaded with a fluid, which you could achieve by pushing a diuretic also. So if they are resistant to the diuretic dosage, certain hospitals are using EECP to increase the urine output. Females, okay. No, I mean, definitely, I think we have seen a lot of, I mean, we don't know, some of the edema is, we don't even know, like they come up with edema. After the treatment, first thing they said is, doctor, for 5 years I had this edema. When I'm taking the treatment, it has disappeared. But we don't know whether it is going to come back after they stop the treatment. But many patients, they complain because that dependent edema, all these things goes up because intracellular volume and increase the urine output. So definitely there is a reduction in edema. But we don't know whether that it will be sustained after completing the treatment. So I mean, we had a registry in India. We have followed up to around 3,500 patients. Most of the center super specialty hospital, their main focus is heart failure. They put EECP only patient with ejection fraction less than 25% who have been posted for cardiac transplant but are on the waiting list. In spite of this high risk, I would put up the mortality rate during the treatment. I mean, when the treatment is going on, somebody is dying with an MI is almost 0.1%. We have not seen so far. And there is only one patient, the aneurysm, actually it was reported to the FDA and they have incorporated it as a contraindication, aneurysm. Usually FDA have not talked about aneurysm. One patient who was undergoing renal dialysis went to EECP, suddenly collapsed. And later in the autopsy, they found out is a rupture of the descending aorta, which has an aneurysm. So it was so the problem is every patient we are not going to screen for aneurysm, but if they have a history, if there is any speculative that he might have aneurysm, we should screen out and rule out aneurysm. We have our own consent form. So we will, before taking a patient on EECP, we are going to explain to them what is the procedure. If they have a poor LV function, we might also tell them there is a chance that you can go for a pulmonary edema and you might require a couple of days of hospitalization. All the consent form will be taken inside the center after the patient is referred to the EECP. No, we will put a medical officer who is a medical person who will do a counseling and take a consent form. Doctors, yes. Doctors, what the consent form, our doctor also will sign that the consent has taken along with the patient or patient first degree relative. Deep vein thrombosis is one of the relative not absolute relative contraindication for EECP. So theoretically there is a chance if you have a big thrombus, it can dislodge and causes a pulmonary infarct. But even patient with deep vein thrombosis, we have not got any patient who have a deep vein thrombosis because it is very difficult to screen. Most of the patients, they may say the claudication pain and they may have a thrombus. No case has been recorded, but if you see a patient with deep vein thrombosis, we may better reject them for EECP because there is a remote chance it can cause pulmonary infarct. In the sense, the amount of blood flow increase, the diastolic, for example, if you ask a patient to improve the diastolic augmentation as shown, he should be running for 10 kilometers to reach that amount of augmentation, where no cardiac patient or no normal patient can do, or even a subject who have no coronary artery can do. So EECP, we achieve such a high amount of augmentation. Even in cardiac rehab, if you put a patient on a slowly on a treadmill, you are not going to achieve this much of augmentation. So I would not say directly, but combining EECP with cardiac rehab have a significant effect, which we are actually doing in our own center in Rayapeta. After 15 sessions of EECP, the patient who are doing only 1 or 2 meds will start doing 5 to 6 meds. And we'll ask them to sustain these IR meds during the completion of the treatment and during the follow-up period. So I think there is a great potential to combine EECP with cardiac rehab, but I would say EECP is a higher form of a cardiac rehab rather than similar to cardiac rehab. See, most of the, as doctor said, most of the patient with cardiovascular disease, if you have a stenosis in coronary artery, atherosclerosis is not only affecting the coronary artery, your entire vascular system. So they may also have a peripheral vascular disease. But if the peripheral vascular disease is so severe, if the iliofemoral junction itself is obstructed, then whatever amount of pressure you put in the leg, it is not going to translate into the aorta and into the coronary arteries. But if there is a peripheral artery disease, and when you do a counter pulsation, if there is even a minor augmentation, as a treatment progress, the blood flow also significantly improve, and the endothelial function improves, peripheral vascular disease also a little bit.